Welcome back to Midnight Med. This video is on compartment syndrome. Firstly, let's define compartment syndrome. So as the name implies, compartment syndrome occurs when there is a buildup of pressure in a compartment, and this results in reduced venous outflow and arterial collapse. This subsequently results in decreased perfusion because the venous flood's not going out, and when you perfuse insufficiently, you get ischemia by definition. This diagram shows the different compartments that can be affected. So causes, so what can cause a buildup of pressure in a compartment? Well, any trauma can, any fractures, any bone fractures, and then you have pressure on the muscle. Or the pressure could come from restrictive casts, which are far too tight and they're on for too long. Or burns. It doesn't have to be traumatic, it can also be non-traumatic. So what else can cause a buildup of pressure? Basically, if there's too much blood or there's not enough blood. So shock or coagulopathies. Or sometimes when you manage compartment syndrome, the increased blood flow itself causes a buildup of pressure and a rebound compartment syndrome. Clinical presentations, so early signs, are based around the fact that you've got ischemia. So firstly, you've got pain out of proportion. So it looks okay, but then it feels a lot worse for the patient, especially when you touch it. And passive movement worsens. So that's when you move the leg, not when the patient's walking, for example. The muscle will also feel woody, and you will see some swelling, as shown in that diagram. And then later stages, when you have severely compromised blood flow, you'll end up looking pale, very cold, as well as pulseless. Those are all, your arterial insufficiency signs. It really links to ischemia. And neurologically, you can also get paresthesia and paralysis, which again are other arterial insufficiency signs. Complications, you've got to think about what happens if a muscle doesn't get enough blood. Well, it could die. So muscle necrosis, contractures with the healing. You've got nerve lesions and nerves that can be involved. Won't be getting enough supply and can be damaged. You can have rhabdomyolysis, which is going to be a separate post, as well as rebound compartment syndrome, which I talked about in the causes, when you have suddenly an increased blood flow, and that causes a buildup of pressure. Investigations, usually it's a clinical diagnosis, so you're looking for those early and late clinical presentation signs, but if you want to confirm it, you can measure compartment pressures. And now the important investigations to do are your pre-op bloods, because they will require surgery immediately or as soon as possible to save the limb. So management-wise, supportively, you have to elevate the limb. Elevate it, remember, because you want to take blood away from the leg. You want it to return back to the heart. Analgesia, the patient's in pain, give them some analgesia, like common sense kind of stuff. And nil by mouth, as with all pre-surgery things, you don't want them to aspirate. In terms of definitive surgery, you've got an emergency fasciotomy, and then you dress it in moist gauze. The fasciotomy releases the pressure because, remember, pathophysiology all about build-up of pressure. Now, there may also be a risk of infection, in which case you can do a debridement, surgical debridement as well, and a washout. You usually would, regardless, give antibiotics, so you think your empirical ones, your gentamicin, ampicillin, metronidazole. Now, I said that you should do it as soon as possible, because the longer it goes, the more likely you won't be able to salvage the limb. Now, the number itself can differ, but generally we say over 36 hours, there's a good chance the muscle is dead and you'll have to have an amputation. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.